feel like I've been chosen to present this model, and I'm very glad, Mary, that I didn't get the grid. Well, yes, to put this model into context, I will repeat some of the resilience theory that we have already heard today. As you know, resilience can be defined as the ability of the healthcare system to adjust its functioning prior to, during, or following events, and thereby sustain operation under expected or unexpected conditions. Resilience focuses on the organizational level and not individual behavior, and the importance of adjustments to varying conditions in the work environment, rather than the rigid compliance with standards. This is linked to the idea that work in healthcare cannot be fully specified in advance, so successful outcomes relies on the ability of the worker to adjust to fluid situation and adjust to create safe outcomes. The need for adjustment and adaptation means that there is a difference between work as imagined, as we have heard today, the why, in protocols, procedures, and targets, and work as done in practice. A further insight is that if successful and unsuccessful outcomes arise from adaptive processes, it makes sense to study what goes right rather than focus entirely on what goes wrong. And as it is a much larger sample of what goes right, as Robin explained to us earlier today. The care model was developed as a framework for defining adaptive capacity to facilitate research in the resilience field. It was developed in studies of hospital emergency care units and older people care to guide data collection. It aimed at testing the feasibility of translating resilience theory and practice into practical steps to improve the quality and safety of care. And we have used it to facilitate the analysis of our multi-level case study of hospital teams and adaptive capacity. And this is the model, and healthcare is described as a complex system, and it cannot be fully specified in advance. So it relies on the ability to adapt. On the left, you see work as imagined. It is seen as an intended alignment between demands in the system, such as patient numbers and quality standards, and the capacity to meet those demands. For instance, organization plans, staffing levels, purchase equipment, train staff, and devise procedures and protocols to meet the demands as it is imagined based on past experiences and future projections. In our study, we used this during observation, and then in the analysis, we categorized our findings in what types of demands the teams were facing and what kind of capacities were enabling adaptations. Demand and capacity can, however, never be completely aligned because of the complex nature of the system. There will always be unforeseen demands, variances, and interactions that requires workers to adjust. In the care model, work as done refers to the adjustment that are required to accommodate these misalignments and the natural variability in how tasks are carried out. In our analysis, we categorized all adaptation the teams did to get a deeper understanding of the range. For example, teams adapt by prioritize, seek help inside or outside the teams, they change their workflow, and so forth. Outcomes on the right are viewed broadly and include consequences for patients, for staff, and for the organization. Success and failure are not fixed categories, but subject to interpretation and judgment based on the context. Competing demands and complex network of stakeholders with diverse needs mean that goals are prioritized and often traded off to produce acceptable outcomes. Contextual factors such as available staff expertise and time and patient load. For example, it might not be possible to meet standards for the optimal patient experience when there is an influx of high acuity patients who have higher care needs than anticipated. Staff in this situation will prioritize or trade off conflicting goals to achieve the best outcome. And since the model is based on system theory and contains feedback loops, there is a non-linear structure. Outcomes are never endpoints. They can affect all other aspects of the model. For example, adaptations or adjustments that are deemed successful may be codified in procedures and protocols and become incorporated into work as imagined on the left side. In our study, we saw, for instance, that adaptation made under COVID-19 pandemic was included in procedures as they had been very successful. And some final thoughts on the care model. No adaptation is right or wrong in itself. In a slightly different context, it might prove different. Elements of the healthcare system are not fixed in terms of whether they provide capacity or introduce demand. For example, a training course can, from one perspective, be seen as a demand requiring the release of staff, but might simultaneously be seen as an increasing capacity in terms of new skills or knowledge. And success for whom? This may differ based on the perspective. Organization and patients or staff may consider the outcome differently. Thank you for the attention.